to treat today's event as a safe space and to ask our panellists any questions that you want to in that spirit. We've got a great lineup for the panel today, and really pleased that we're covering quite a broad range of different collaborative models. You might have noticed that some of the national narrative has tended to focus a little bit on horizontal collaboration at scale, and sometimes tended to talk a little bit more about acute and mental health, but we're of course interested in all forms of collaboration, so whether that's at scale or at the level of place, and certainly those collaborations involving acute mental health, community colleagues and the ambulance sector as well. We've got a great breadth to share with you today. So really warm welcome to our panel this afternoon. We're shortly going to hear from Michele Moran, who's Chief Exec of Humber Teaching NHS FT and lead for the Humber Coast and Vale Specialised Mental Health, Learning Disability and Autism Provider Collaborative in Humber Coast and Vale ICS, and she'll be talking to us today a little bit about that. Welcome to Siobhan Melia, who's Chief Executive of Sussex Community NHS Foundation Trust, and she'll be talking about her work with a community and primary care provider collaborative in Sussex Health and Care Partnership, ICS. And welcome also to Kevin McGee, who's Chief Executive of Lancashire Teaching Hospitals, NHS FT, and also the lead for their provider collaborative, which covers 4 acute trusts in Lancashire and South Cumbria ICS. So a great range today. Just a couple of housekeeping bits from me before we kick off and get into our presentations. We are recording the session, as you probably heard just there. That's so we can share the playback with yourselves, along with any slides that are used, and so we can share it with a broader audience as well. Please try and keep your microphone muted if you don't mind during the presentations. That would be great. Do use the chat box as much as you want to at any point, either to leave a comment or to pose a question. And if you would like to ask a question of our panelists audibly, there should be a raise hand function somewhere there on Zoom. If you can't find it or it's simply not there, just wave or indicate to me in the chat that you'd like to come in, and we'll make sure that that's the case. Michele does have to dip out for another commitment midpoint. So we're going to hear first from Michele and then go straight into Siobhan's presentation. And then we'll pause for some Q&A. Then we'll hear from Kevin, and then we'll have further time for Q&A with the panel as a whole. So without further ado then, I'm going to invite Michele to give us her presentation. I think you've got some slides, Michele, haven't you, that we're going to put up?
I have, thank you. Good afternoon, everybody. I am unfortunately nipping out, but I'm going to try and get back for the Q&A session. But if there is obviously some technical hitches, then please do send me any questions if I can help. Then I'm more than happy to. I've been leading the provider collaborative discussions at Humber Coast and Vale for a while now, and I'm just going to take you through the mental health. I'm just going to give you a bit of an overview about our provider collaboratives, and you see where the mental health one fits in, and just some of the successes, but some of the challenges and some of the governance aspects that we've been working through. So if we go on to the next slide, please, that'd be great, Laura. So Humber Coast and Vale is an extremely large geographical patch. We've got 4 acute trusts, and they operate across 9 states. Can we all just pop ourselves on mute if we're not? I'm getting some feedback. Thank you. We've got 3 mental health trusts. We've got 4 medium to large not-for-profit providers, community interest companies, 34 PCNs, 2 ambulance trusts, 6 CCG, 6 local authorities, just under 1.8 million people, and a budget of 3.5 billion. So we've got an exceptionally large patch, but it's also rural, coastal, urban, etc. So we've got a really quite a different demography as well. Next slide, please. So we've been devising over the last sort of 2 months 4 collaboratives. We sort of turned it into 5 because we've got a voluntary sector one now, but these are the 4 main ones that we've been working with. The acute collaborative, community, primary care, which is a PCN collaborative, and the mental health and learning disability one. So if we go on to the learning disability one, which is what I'm chatting about today, if we go on to the next slide, please. So the mental health one has been probably up and running a couple of years. Actually, it started off as a partnership. I started it off as a partnership, developing the content of the long-term plan and the mental health investment standard. So we've sort of built it up from there and into what is now our provider collaborative. So if we go on to the next slide, please. So our main priorities And I think it's important for any collaborative to start to define their priorities fairly quickly, and all the four have now. All four have got work plans and work programmes. I think that's important because it gives us focus. So we've done some immediate ones up until April, and then we've started to think about the longer term ones. But these ones for mental health were all built around the long term plan. So autism and learning disabilities, that actually came into the collaborative just at the start of COVID, because it was a separate part, but we brought that into the collaborative programme. Children and young people's mental health, IAPT, particularly SMI, targets and community mental health, obviously the crisis care pathways and building that mental health resilience, and that's not just within the mental health and learning disability field, but that's within all our partner organisations. And then perinatal and mental health, maternal mental health, and the maternity mental health is actually being done really closely with our acute trust, and that's how we're starting to link the provider collaborative work together. Suicide prevention and individual placement support. So if we go to the next slide, which I think is important for this afternoon's discussion, this is the current governance structure. Now, this is our third governance structure. We didn't do a committees in common because I think sometimes, especially when you've got such multi-providers, it can create more barriers and difficulties. So we've always worked on a memorandum of understanding and a partnership agreement, and we've continued to do that. This is the latest one because obviously we've gone from an STP when the partnership was started into provider collaborative territory, and also into now an ICS. So what you have at the top is you have the system assurance. So that's where the system, the ICS, is starting to get its assurance from, and that's at the partnership board where all the chief executives and chief officers are at. The other box, which we're finding to see more and more, oversight and accountability, is the NHSEI regional and national team. In fact, my week this week has been predominantly with the national team, accounting for the ICS Mental Health and Learning Disability Collaborative. So they're beginning to get more and more involved with that work. So they're the two assurance pieces. The ones in green, and we've only done this to try and make it quite simple, because this is as simple as we could get it, believe it or not, is the programme assurance. So if we're talking about those priorities, where does the programme get their assurance from? Not reassurance, but assurance that the providers are delivering the targets and the metrics, and the commissioners at the moment, the CCGs, are delivering the financial aspects in relationship to the mental health investment standard. And we do that through an executive leadership group, which we've got partnership agreements for and memorandums of understanding, and we meet bi-monthly. We did meet monthly, but because of the subgroups that we've got and the work that we're doing, we found it more beneficial to meet bi-monthly, and we constantly review that. And that is supported by an oversight and delivery group that meets monthly, and that takes all the trajectories, all the finances, because we brought about £27 million of extra funding into this structure because I think of the processes that we've got, and they monitor that on behalf of the partners. And then we've got individual work streams for the programmes and a really strong clinical assembly. And our clinical assembly is supported by, we've got two senior clinical leads within the collaborative team, both consultant psychiatrists by background, and they actually spearhead the clinical assembly. And each clinical assembly we can have up to 200 clinicians across the patch attending, which is phenomenal, and they shape and influence the delivery group and the oversight group. And then the areas in red that are beginning to develop more of the place, we've got 6 places, and we've always said that the place is paramount. So even a couple of years ago when we were setting up the programme, everything needs to be done where it possibly can be at place, and place need to be accountable to themselves as a mini soft system, and then that's fed into the wider geographical patch. So they're the 6 places, and at the moment obviously they're looking at maturity index and maturity scales. You'll see 2 in the top, and then Humber are slightly different because we've got 2 geographical partnerships. So In the Humber part, we've got Humber 4, which is the Humber Geographical Partnership, and then we've got North Yorkshire and York, because our 6 places are York and North Yorkshire, which form the North Yorkshire and York Geographical Partnership, and then Hull, North Lincolnshire, North East Lincolnshire, and the East Riding, which creates the Humber 4. And then what we've also got feeding in through the governance, but not a direct reporting method, is various planning call meetings, because we get obviously different planning structures coming out, different instructions in relationship to the programme trajectories, because we've obviously got several programmes. So we have weekly lead calls for that, but the team tend to do that and then feed those into the oversight group. That is constantly evolving, and why I say we will review it, because we'll review it as the place develops and as we start to look at the geographical partnerships. So one of the things that we've learned is it's really important just to keep it as simple as we can, keep it based on assurance, but also just to keep reviewing it and keep checking in to say, is it meeting what we need it to do, which is to deliver outcomes, but also to provide the assurance and data sets that we need to hold ourselves to account. And then obviously ultimately the system will hold us to account for as well. And at the moment it seems to be going really well. We've got really good uptake, and we have got some improving trajectories and plans, etc. So that's what it looks like at the moment. So if we go on to how we've done decision making, because decision making is quite interesting, especially when we've got financial and money in place. So we set ourselves some principles very early on, but planning and investment decisions need to be based upon population health, and we're not thinking of changing any of these as we go into most of the collaboratives that, because I'm designing the whole of the system with colleagues, will work around these set of principles. A multi-year approach, wherever possible, we're trying to develop. We know the funding is slightly different. Well, that shouldn't stop us looking at longer term priorities and longer term strategic objectives. Obviously, we need to flex it and accelerate it depending on funding, etc. But we should be thinking a bit wider than just an annual process. We are desperately trying to level up, and we do set our decisions wherever we can in relationship to that. We are making learning disability and autism a priority in our collaborative, because it has been particularly underrepresented, I think, through just through circumstance rather than anything else. So we are making that priority, but more importantly, the planning has to be collaborative. So we've got a really good, as I say, collaborative oversight group that and officers do attend, which is really great. And we do want everything that we do to be as collaborative as we possibly can be. If we go on to the next slide, please. So I think some of our quick successes that we've had are the governance structures, and we have got agreements in place. And as I say, we've got a lot of partners, a lot of different partners as well. And we have got agreements, which is fantastic. We have got several services and pathways delivered, some by single providers, some by joint providers, and some by individual organisations. We've been quite successful in getting early adopter status, such as community mental health teams, children and young people, and we've also got the specialist commissioning lead provider, which is secure services, eating disorders and children and young people, and that's the whole of the specialist commissioning budget. And as I say, one of the great successes has been the clinical assembly. So we asked our partners on a timeout to draw or to design what it looked like before the partnership, and this is what they came up with. And we wanted it to be fairly visual, because we could do a lot in words, so we wanted to do it in pictorial if we could. So this is what they came up with. So go on to the next slide, please. So what they said was that we often worked in silos, that we often misunderstood each other because we talk a slightly different language, and this obviously goes from our local authority partners as well. We always duplicated work. We always did it 5 or 6 times. I'm not saying we only do it once at the moment, by the way, but we were always seeming to be duplicating work. We did avoid difficult conversations with each other. Not all the time, but sometimes, especially when it came to decision making and funding, and we were just confused for our patients on the pathways. Were just really quite confusing, and we always thought about our organisations first. And I come from an FT, so obviously that's in the organisational structure, but we always did. So what's different? So then we asked them to do what we think of it is now. By this is no means utopia, by the way, but this is what they think of how it's felt a little bit further down the partnership line. And we're going to do this on an annual basis. So we're on to the next slide, please. It might have gone back. So we have built relationships. And as we know, really great collaboratives is built on relationships. We do talk our way, and we do find our way through difficult conversations now. We try to reduce variation. We did a lot of variation across the patch, and our data sets are showing us that we're reducing that. We have still got variation, but it's reducing, and we are streamlining our services. For example, we've got 2 or 3 key services that are led by one single organisation, who then contracts with another organisation to try and streamline those services. We've improved outcomes for the community. We know that by some of the latest data, and some of the really impressive latest data is we invested quite a bit of money in suicide prevention, because we were an outlier in suicide cases, and that was mainly partly because of the bridge, the Humber Bridge, and we set up a multi-agency collaborative suicide project, which was in the collaborative, and we've just found out that we've made the biggest impact in the north of England, and we are now no longer one of the outliers, which is fantastic. So that just shows you by doing things in a multi-sectoral way, it is important. We do share information. We had a bit of we were quite, because of all the other things, we were quite difficult in sharing information, but we do share information widely now across all the different partners. And more importantly, we are planning for the future together. And I think that the collaborative work that we're doing from an ICS point of view now, from the legislation point of view, is only going to build and cement some of the work that we've been doing over the last couple of years. So some of the challenges, if we go on to the next slide, this is across all the collaboratives, not just the ones, not from a mental health point of view, but there is still this conversation that we're having about sovereignty of governance and collective governance. So we're still having conversations about how we can manage that process going forward. One of the things that I'm having lots of conversations with each of the local authority chief executives and the chief executives of other organisations, is how we link the horizontal working and vertical working together. Because we've obviously got place developing at speed now and with maturity, which is great, and obviously the ICS, and then the provider coming on from a horizontal point of view. So what should be done at place and what needs to be done within the provider collaboratives, and we're still having that conversation. We've got some aspects of that, and I'm sure that will continue over the next 6 months, 12 months as well. There's expectations that funding flows will be different, and we've already seen some of that, certainly from the mental health specialist commissioning point of view. And obviously we're talking quite closely about the mental health investment standard coming into the provider collaboratives, and we need to look at how we can do that and how we can develop the functional form of the provider collaboratives rather than the actual structural form. And we're doing that with the ICS as the ICS develops at the moment. So we've plotted all the functions of the CCGs and the ICS, and we're starting to look at where is best for those functions to take place, and where does the current resource go. Because all the work that I've been describing with the mental health, we've done that on the back of not having a lot of resource. So we need to start to build on that. The other conversation that we started to have, and we're building through, is the importance of creating concept of responsibility rather than accountability. And what I mean by that is having system accountability and collective accountability, but seeing it as an integral element of the ICS governance, that it's not separate. So it's all joined together. And then capacity to operate at each level. And this is obviously something that we're looking at closely in Humber Coast and Middle Coast. We've got the geographical partnerships. So how do we manage the capacity in the ICS, geographical partnerships, place, neighbourhood, and the collaboratives? And that's why we're mapping our resource envelope that we've got at the moment. So that's some of the challenges that we are working through. We've overcome some of them, or we're getting to close point, but we've still got to clarify some of them. So go on to the next slide, please. So successes, we've got the 4 up and running. They've all got their work plans. They've all started to look at real key objectives and, as I say, key priorities for the next 6 months. I think we've got a really positive mindset in Humber Coast and Vale about and the ICS about working collectively as providers. We've done, as I say, we've done some of that, a lot of that already. Providers are prepared to take on ownership and develop the key programmes of work, which is fantastic. All of the providers. I think there's a full recognition now that we do need to shared access across the patch. My organisation is hosting the Yorkshire Care Record, which I think helps that data collection as well. We've got an ongoing process now where we support, develop and work with the collaboratives to ensure that the relationships is based on clear understanding, and we've done some behavioural framework work with them as well. We've done a bit of a commission scenario planning work, and we'll continue to do more of that, and that just tests out the governance structure and the structures in place. And we've got a lot of engagement with the local authority, who are actually saying at the moment they want to concentrate on place, but they'll come back to the provider collaboratives, which is great. They're still providing that advice into the strategic design of the collaboratives. So the next steps, which is on the next slide, please. So obviously to continue to develop our collaboratives, we're looking at an overarching collaborative assembly. Now, whether that's a collaborative of collaboratives or just the assembly, but how do they come together and how in that wider field, so we don't work in silos, because there is a lot of cross-reference between the collaboratives, not just with place but within each other, so we need to be mindful we don't lose that. And then we're doing a lot more scenario events with funding flows and outcome focused over the next 2 to 3 months. And I'll stop there and maybe take questions, but hope that was okay.
Fantastic, Michele. Thanks so much. Really comprehensive and rich. Can I just do a bit of a time check? How long have we got you for before you need to dash off for your next appointment?
10 minutes. Is that okay?
That's absolutely fine. So let's rejig a little bit. We'll take a few questions for Michele then while we have her, and then we'll hear from Siobhan in a few minutes, if that's okay. I've got one to kick off with while colleagues get their thoughts in the chat, or do raise your hands as well. I really like the sort of before and after the partnership slide, Michele. I just wondered if you could maybe unpack for us how the partnership's gone about trying to move that cultural change piece along. Were there any sort of practical steps that underpin that have kind of helped take people on that journey from the before to the after?
Yeah, it's a good question. I think a lot of it has been based on that trust, building up the trust and getting to know each other. So we did a little bit of work about getting to know each other as individuals as well. So we've done some behavioural framework work and some OD work, because I think that's just as important, because we do it within our own organisations, and we're developing a system-wide structure. So we did that, and just starting to having some, I think it's having some rules of behaviour was helpful to challenge each other in an appreciative way, and that then builds up the trust and enables you to have that difficult conversation. But it has taken time. Don't forget, we're talking about a couple of years for this particular collaborative, but we're doing the same now in the other collaboratives as well. So behavioural framework, keep chatting about things, working through things, and it's that collaborative. Some of the decisions that we made earlier on were quite painstaking, laborious, because I actually spoke to each individual chief exec and went through the process, what we were doing, why we were doing it, and then collectively, and that obviously took time. But I think it allowed that trusting behaviour to develop, if that makes sense.
It does, thank you. Yeah, it's just great to get the perspective from a sort of series of collaboratives that are just that little bit more mature. It's really interesting. So thank you. So I can see a hand up from Lizzie. Lizzie, apologies, I haven't got your surname on my screen, but do you want to come in and ask your question?
Hi, it's Abdurrahim. I'd like to better understand the point that you make about the importance of responsibility rather than accountability.
Yeah, and I think it's both. And there's a responsibility to develop our outcomes and responsibility to our communities and those people that we serve. There is a responsibility, a duty. The accountability, if we start to talk about accountability, we get wrapped up in organisational accountability, especially obviously the FTs, who have got obviously the mandate in relationship to being organisationally focused. So there is an overarching issue that system is going to be accountable for itself, but I think we as individuals, as leaders within that, have to be responsible and have that responsibility to deliver that accountability. So we've attacked it from that end, and that's been really successful, because I think it's allowed us to break down more of our organisational boundaries than not. For example, we got some money for the Resilience Hub in, and I took the responsibility not to allow our organisation to put up for that money, because I wanted to demonstrate the trust, the behavioural structure. So we got the other providers in the room and said, right, this is the money that we've got, how are you going to provide that service? So I think there's a responsibility as opposed to, because at normal accountability, I just said, oh, my organisation needs to be just as important as everybody else's, but and we're tending to do that more.
I'm just doing a scan for other hands. Can't see any at the moment. So thanks ever so much, Michele. I suggest if we let you get to your next important appointment, which is also associated with NHSP, and then we'll hope to see you back for the panel at the end. That was great. Thanks so much.
Thanks all. Good luck, everyone. Thank you.
And we're next going to hear from Siobhan, who's going to talk to us a little bit, I think, from a community perspective around building a collaborative with primary care colleagues as well. So thanks, Siobhan. Over to you.
Thanks, Miriam. Hi, everybody. So my name is Siobhan Melia. I'm the Chief Executive at Sussex Community NHS Foundation Trust. I'm just going to spend a few minutes describing the journey that we've been on in Sussex with what's called our Primary and Community Care Collaborative Network, shorthand PCCN, which has taken me about a year to get right. But so I'll just give you a little bit of a potted history about why we've got this collaborative, because as I speak to people across the country, I think there's always a bit of a dilemma about how to bring primary care into a collaborative, or whether to bring primary care into a collaborative. So I thought it might be useful to focus a little bit on the rationale for us in Sussex. So this conversation started probably just before the pandemic, around about the winter of 2019-2020, when we were looking at the kind of strategic forums that existed in our STP just before we became an ICS. And so back in the early throes of kind of January, February 2020, we had two collaboratives in Sussex. One was a very, very established mental health collaborative. Listening to Michele, there's lots that resonates about very long established working relationships, governance structures, budgetary responsibility, delegated commissioning. So we'd had that collaborative up and running for a couple of years. And then we also had an acute trust collaborative, and I'm interested to hear what Kevin says next, but ours was a similar acute trust collaborative across 3 or 4 different acute organisations. And what I think was becoming really clear when we were coming together as chief executives is that the collaborative leaders were able to influence some of the strategic priorities for the STP as it was at the time. And I felt quite strongly that there was a gap in shorthand with, say, the out of hospital care sector. So I began to talk to the ICS leader, and we decided that we should probably go for a 3rd collaborative to create that kind of strategic balance around the table. So I agreed that I would chair the collaborative, and we agreed that it would have quite broad membership. So the membership has been, there's 2 community providers in Sussex, so the chief exec of both around the table, a range of CCG and ICS kind of leaders and clinical leaders, and importantly, primary care network clinical directors. Now, I felt quite strongly that PCNCDs should be the representative voice for primary care as providers around the table. One of the challenges we had in probably spring into summer of 2020 was not everybody held that view. So, for example, GP federations in Sussex felt that they should have the seat round the table because they were representative of a group of GPs who were members of their organisation. How I managed that was I brought a GP into the kind of development of the collaborative space, and he and I would go around and visit virtually as it became many GP meetings and forums to explain why the primary care network clinical directors were the right voice, we believed, as providers of what hopefully will become even more joined up care around local neighbourhoods and local communities. So that's where we started. The purpose we set, and it is really important to have a clear purpose, we set a fairly simple one, which was that our collaborative would enable the ICS to deliver the ambition in the NHS long-term plan. So we kind of pivoted ourselves to a common purpose that was a policy document that for the first time elevated, we felt, the role of primary and community, talked about proportionate investment over time, talked about standardization of care models. So we felt that that was probably the best starting point for us. In terms of how the governance has evolved, I should say we kicked off the collaborative in the summer of 2020. So we've been going just over a year now. We started out having kind of parity in terms of reporting with the other collaboratives, i.e. Myself as the chair and the other two relative chief execs would provide reports into our monthly ICS chief exec level partnership meeting. So there was a kind of oversight and escalation point that still exists now upwards into the most senior ICS partnership meeting. The governance that's probably evolved more is the governance underneath the collaborative, as we've kind of expanded some of the work programs and as things have come down the line nationally. So we've probably got kind of three main areas. The first one is the Aging Well program. So we absolutely have had very good focus on enhanced health in care homes, urgent community response, and soon to come down the line, anticipatory care. So it's created a really good place to level up and make sure that we've got standard operating models as per the new national specifications. We've also used the governance there as a place for the people who are leading on kind of clinical networks where they're developing pathways of care around long-term conditions. Again, back to the navigation to the NHS long-term plan. So, you know, stroke pathways, cardiovascular, respiratory, diabetes. Although they're end-to-end, and obviously they have a really big imperative with our acute trust partners, we decided to try and create a bit of a focus in what should happen outside of hospital in people's local communities, and to get kind of a broad range of clinical insights. And that's gone quite well. The teams who are leading on some of those pathways have created new clinical leadership networks in Sussex and have also managed to get some funding down from national pots of money as well. So the second area is long-term conditions. I should say we've also had an overview on the post-COVID assessment service in Sussex. Whether that actually becomes a long-term condition over the fullness of time or not, it felt like it was the right place for us to absolutely have some oversight there. And the third area is kind of wider primary care developments. Now, I think the thing we haven't done enough of is look at primary care transformation, and we kind of recognise that the COVID vaccination programme has certainly taken a lot of our time in the community and primary care space. But I think over the fullness of time, having a bit of oversight around primary care transformation will be good. We do that through things like pharmacy and integrated pharmacy medicines optimization transformation program, which has been a massive piece of work across the patch, has had some really good oversight and challenge and engagement through the group. So we kind of stick to our purpose as being, we don't have a delegated budget, we don't have performance and assurance oversight. What we do have is a strategic, transformational, forward-looking, reducing unwarranted variation and navigating ourselves to the ambition in the long-term plan. I think some of the governance challenges that we've had, and Michelle covered this, what happens at collaborative versus what happens at place has been a challenge to date, and I think will be probably the biggest knotty issue for us to continue to work with as the ICSs develop. The role of the primary care network clinical directors in governance terms, what are we asking of them? They're not representative of their group. We've tried to maintain their role as being a GP leader, providing services in the primary and community space in a particular neighbourhood or community, rather than asking them to be representative of groups of GPs in a particular part of the patch. And the third area I would say in terms of governance challenges has actually been the interface between the three collaboratives. And I think there is a risk with collaboratives that we end up creating silos without meaning to. So I gave you an example of some of the long-term conditions pathways. The acute collaborative have been looking at stroke. Our collaborative's been looking at stroke. The mental health collaborative's been looking at stroke. We do run the risk of not necessarily joining all the dots up. So there's some work for us to do moving forward, I think, around how we don't in an unintended way create further silos by having collaboratives that are kind of almost very specific to the sectors in which we work. So I think that's going to be an interesting one. In terms of the lessons learned, I think I would totally echo Michelle's first point in her slides. Relationship building has been the thing that has both taken time but has been key to our success. The second thing I would say is, for me, the content of what we were discussing, particularly in the early days, was not really necessarily the most important thing. And I know that sounds a little bit controversial, but I reflected on the meeting we had last week when we had 5 different primary care network clinical directors around the virtual table, engaged in all sorts of debates about all sorts of matters. And I reflected that engagement and contribution was quite narrow a year ago. So I think building a space where people have strategic influence, they can see that their voice is heard, is really, really important. And that does take time to build the relationships. I think agreeing a purpose early on and trying to find where the shared ambition is probably the other big point for us. I think we could have come at this collaborative from a range of different perspectives. In Sussex, we recognise that the mental health collaborative is very different to the acute collaborative, and the acute collaborative is very different from the primary and community one. We're serving different purposes, but we believe that we're all adding value, both to the patients and populations we serve, but also to the wider strategic ambition of the ICS. So I think in terms of the next steps, I think for us, the role of place-based partnerships, so we've got 3 places in Sussex, which are coterminous with the upper tier local authorities. We know that place-based partnerships are going to go from strength to strength. And I think it further exacerbates that real dilemma around what is the role of the provider collaborative and what is the role of a place-based partnership across multi-agencies, multi-sectors, and focused on communities, neighbourhood, places, and reducing health inequalities with the public health leadership that we have in our councils. So I think we're in a good place. I think our ICS does value the 3 collaboratives, and certainly our intention is to keep the 3 collaboratives as they are as we transition into the statutory organisation in April. I guess the last thing I would say, and I have reflected this to colleagues at NHS England and Improvement, is the guidance coming out which reflected the significance of provider collaboratives through the lens of acute and mental health organisations did for us feel like a little bit of a retrograde step. So although the guidance, the final guidance, was permissible enough to allow the ambulance sector, community, primary care to join in collaboratives, I think it did run the risk of removing some of the great work that systems have done that has been bespoke to how systems have evolved and worked together. And certainly the value of the primary care and community partnerships, the strategic voice, has been really, really invaluable in Sussex. And at one point, I think that could have been blown a little off course with the guidance just focusing on mental health and acute. That said, I think in the drafting of it, it did obviously end up being more permissible and allowed us to state our claim in Sussex as to why we should continue with the direction of travel that we're on. In the fullness of time, when the ICS is embedded and place-based partnerships are thriving, I've no doubt that provider collaboratives will look different again. But for now, I think it's a great vehicle to keep focused on delivering the ambition in the NHS long-term plan. So I'll probably pause there, Miriam, and hand back to you.
Thank you, Siobhan. Again, a really rich and I think very honest presentation as well. So thank you ever so much for that. I'm going to open it up to the floor for questions to Siobhan on what she talked about there. And while you're having a little mull about your questions, I'll just use Chair's prerogative to come in with a couple. You talked a lot, Siobhan, as did Michelle, about the kind of tensions between this sort of lattice of working at scale and kind of working at place, so what gets done at what level of population, and you said that's work in progress, but I wondered if there were any examples where you and colleagues have kind of resolved that tension successfully, or kind of any sort of service areas we could use as an example, or any practical tips about how you maybe went about that conversation that might be useful for colleagues.
Yes, it's a good question, Miriam. I mean, one that does spring to mind that's gone particularly well is the delivery of the enhanced health in care homes, national kind of specification. So I think, you know, we were able to look at that at county level through the collaborative. We were able to kind of debate how to implement that to get the greatest outcomes for people in care homes. And of course, this was through the terribly challenging course of the pandemic, where the care home sector was impacted so dramatically. So it became a very early priority for us. I think we agreed what good would look like in Sussex. We agreed a kind of funding model, commissioners around the table with us, but actually the delivery of that was very place focused. So it was very local, working, you know, care home by care home with the GPs who had registered listed patients in care homes, you know, our community teams who were geographically allocated to it. And so I think, you know, in simple terms, you can take something that is, you know, a national mandate. You can look at what good looks like at a kind of super population level, and our Sussex population is 1.7 million. But when it comes to the nuance of delivering change on the ground, I think for that particular programme of work, focusing on oversight at place, looking at the public health intelligence about, you know, risks in care homes and the demographic data from the JSNAs, all really did help to bespoke, I guess, the delivery based on the different patches and the scale of the challenge. In some parts of West Sussex in particular, the number of care homes is astronomically higher than national average per capita. So there's some real kind of bespoke challenges that need to be taken into account. I think moving forward though, so I think we started with a, you know, at Sussex level, at ICS or collaborative level, let's set the standards, let's look at best practice, let's try and level up funding and resource allocation, and let's deliver at place. I think that probably the ask over the next couple of years is quite different. I think as I read it, places will become much more than just the delivery vehicle of what is agreed at a kind of ICS or collaborative level. So I think it's okay for now. I think it kind of makes sense to focus on nuanced delivery based on population need. But if place-based partnerships become much more and end up with kind of budgetary responsibility, integration of health and social care around local authority and health partnerships, then I think the ask becomes quite different.
Thank you, and it's likely to evolve further, isn't it? Really helpful. Well, one further question from me before we'll perhaps then pass over to Kevin. But one more from me, Siobhan. It sounded from the way you described things as if you invested quite a lot of personal leadership time in getting the community primary care collaborative together, and you talked about sort of going around GP fora and engaging with the clinical directors. So I just wondered how you humanly managed to do that. Did you have to backfill, or did you just sort of make the time? Because you know, leaders are very stretched at the moment, aren't they? And all this transformation is another draw on people's time at a time of considerable operational pressure. So I was just interested in how you personally managed that. And then I'll come to David, who has got a question as well.
Yeah, thanks, Miriam. If I'm honest, it's a bit of a blur now, because the real kind of grind on this was probably, you know, it was probably just as the pandemic hit. It was literally February, March 2020, through to the point that we got it off the ground in the first meeting was August 2020. No backfill, just a bit of a passion to kind of have our voice heard. And as I say, I wasn't alone. I had some allies, and one GP in particular who was a real strong ally of why this was important, what opportunity it would give for us in the primary and community space. So yeah, I mean, I made the time, I guess, and I also felt it was really part of the day job, because I was starting to feel that if there wasn't a kind of elevated platform to have the community and primary care conversations, that we would struggle to raise the profile of the ambition in the long-term plan and the funding allocations coming down the line. So I believed it to be part of the day job and not an addendum, but it was a grind for 2 or 3 months at a difficult period in time because of the pandemic.
Thank you, I bet. David, bring you in to ask your question. Thanks.
Yeah, thanks, Miriam. Thanks, Siobhan. I'm David French. I'm Chief Executive at University Hospital Southampton. I'm really interested in the sort of getting closer to primary care, and given how they're struggling. And I'm just wondering, given how you're presumably hearing about their difficulties, and you know that they're on their knees, aren't they? Generally, primary care. Does that mean that your direction of travel? Do you think that you become a primary care organisation yourself?
So yeah, that's interesting, David. Yeah, so there's probably two answers to that question. The first is we're a large standalone community organisation. We're an FT, and we were asked to support the system to create further resilience in primary care a couple of years ago. So we do have a wholly owned subsidiary that's been running for a couple of years, where we provide primary care services, and we've got 7 practices in that at the moment. It's not thriving. All the GPs in our practices are on their knees as well. So there is a way in which I think community organisations can support with primary care, but it very much depends on the construct and the constitutional opportunities that brings. For us, it's kind of different as a big standalone. So does my organisation have a role in primary care? We currently do, and we think that primary care partnerships will probably be a part of our strategy moving forward, not least of which because so many of our services operate around the same neighbourhood footprints. In answer to your question about how primary care are feeling and the fact that they're on their knees and that there's a high level of disillusionment, we don't actually talk about that in the collaborative. I mean, there are other places that gets discussed. And I guess I was very clear that if we started with anecdote or too much how it feels, we probably wouldn't find the spirit amongst us to pivot back to what the opportunity is. So one of the ways that it's really important, I think, to not do that for primary care is to not think that we are the oversight mechanism for the GMS contract or the performance data or the percentage of face-to-face appointments. So I agreed with the ICS leader that primary care contracting and performance would not come into our collaborative, and that we would try to keep it at kind of opportunity, partnerships, population focused. So I think that there's sort of 2 angles to that, but it would be easy. And each time there's been a subject around money, or the long-term plan allocation for urgent community response has come down the line to Sussex, it equals X million. The GPs will often ask why they can't access that. And so we kind of go back to, well, this is how our contracts run in community services, and the GMS contract is very different. So in the same way that we can't access GMS funding, there are rules and regulations about NHS England funded services. So I think we're not in a bad place at the moment, but I think, and actually last week I was really surprised that all 5 primary care network clinical directors attended, most of them in their practices, multitasking, but they're engaged. And I think that was my point really, which was the engagement and the dialogue, I think has come a long way in the last year.
Thanks, Siobhan. Great question. I think it's time now to turn to Kevin. Thanks again for your presentation, Siobhan, and we'll bring in Kevin for an acute collaborative perspective.
Thanks, Miriam. And I've been asked colleagues to speak for about 10 minutes in terms of the work that we're doing in Langston, South Cumbria, which clearly I can only give an overview, but very happy to go into any questions and go into more detail in any area. So just a little bit of background about Langston, South Cumbria. We cover a population of around about 1.7 million. We go from Barrow in the north right the way down to sort of Chorley in the south, and in the east over to places like Colne. So it's a big geographical area. We've got 5 place-based systems within that. So our integrated care partnerships We've got 4 relatively large acute trusts or acute community trusts in that space, and we've got 1 mental health, LD, autism provider within that space. Now, we recognised, I think, a while back, and I'm going to say a while back, probably going back about 3 years ago, well before sort of you know, the advent of the COVID and everything else. But we recognise that given the issues that we faced in Langston, South Cumbria, around the health inequalities, and the issues around health inequalities, the issues that we had in terms of our workforce shortages, some of the service issues and quality issues, quite frankly, that we faced, some of the service configuration issues, because if you know, basically, if you came down now, you would not design a health system as it's currently constituted across Langston, South Cumbria. We've got duplication, we've got many things going on, and we've got a significant financial gap. So we recognise that no one organisation could deal with that alone, and that we had to work within collaboration, we had to move in a collaborative way to deal with these issues. In Langston, South Cumbria, I suspect the same as most places in the country, I think historically been characterised by a lot of competition between providers, competition for services, competition for scarce resources. So we were really turning things very much on its head. Of course, COVID came along then and changed the world in which we live, in which we work. And frankly, the only way we've got through the last couple of years through COVID is through working together, through collaboration, through mutual aid. And there has been times over the last 18 months in particular when each of our 4 acute hospitals has been overwhelmed individually, and only by working in collaboration, by transferring activity, by using and supporting staff moving across organisations and the like, have we been able to get through. And that goes from the very early days when we all suffered from the issues of PPE through to current programmes around restoration. So we were on this journey to collaboration and providers working differently well before the pandemic, but certainly the pandemic has hastened our thinking. It's also worsened some of the issues that we face around the health inequalities across Langston, South Cumbria, and the health differences that we face across Langston, South Cumbria. So when we think about restoration now and moving back in terms of our elective programme, the issues that we face around cancer recovery and the like, if one organisation tried to do that alone, they would singly fail, and all we would do is worsen the health inequalities and have differences and differential waiting lists across Langston, South Cumbria, and we're not prepared to countenance that. So there's a real imperative for us to work differently, there's a real wish to work differently, and there's a real recognition that from our perspective, regardless of what goes on elsewhere in the country, it's the only way we think we can do our jobs properly going forward. So in July of 2020, we set up formally a provider collaboration board that consists of chairs and chief executives, and we spent a bit of time at the outset working on a governance structure that would allow us to take decisions together with gateway processes and quite a lot of things behind it. That has worked to an extent. But what has been most noticeable, I think, has been by working and bringing the chairs and chief exec together and forming a collaboration board, the relationship. So you can have all the governance and the work, but as colleagues have said, it's the relationships that were being built up. And one of the things we did at the outset, we appointed an independent chair, David Flory, who many colleagues may know, and that's really helped to challenge us as providers, moved our thinking along, but provides that independence about across organisations, so that we think of things as a system as opposed to individual organisations. So we have looked at our governance and we continually amend our governance, and one of the key sort of things I would try and get over is any governance is only fit for purpose at that point in time, and as the system change, as things evolve, our governance needs to change. And we are, as with everybody else, dealing with the complexities about how do we establish these new ICSs, what will take place at ICS level, what will then take place across our 5 places, and that sort of vertical integration, and then what should take place horizontally between providers. And we're convinced that there's a role for all of that, and all of it needs to be in place. But exactly what sits we're working through, and as a consequence of that, the governance will need to change, and the governance will change. Under the Provider Collaboration Board, what we've put in place is a coordination group which I chair, which consists of like senior executive representatives from each of our 4 provider organisations, acute provider organisations, and that really coordinates the work programme that we've set up. It's the powerhouse. It's the place where we we have the conversations and make the recommendations to go through to form the decision through to the PCB. Underneath that, we've got a group that's really focused, and it's chaired by one of our chairmen and led by one of our chief executives, that's looking at clinical collaboration agenda. And then there's a group that's focused on the support services agenda. So all our back office functions, what they look like, and all the support services. And again, that's chaired by a chief executive and chaired by a chairman of one of the trusts, and supported by and sponsored by the chief executive. So there's 2 big sort of buckets of work, feed through to the coordination group that I chair, and then all the decisions will go forward and through to our provider collaboration group. We're currently looking at how to streamline that governance and what it looks like, and how can we ensure that the Provider Collaboration Board moves from a committee in common into a joint committee that gives us the authority to make decisions. And we're currently working that through, and we think the legislation will allow us to actually do that. So what we've done, and what we've sort of focused on, is really trying to be clear on what are the key priorities and what we're trying to do by working in this sort of collaborative way. And we've set ourselves 6 very big priorities, and there's a lot of work below them, but I'll just quickly sort of mention the sort of 6 priorities that we've got. So firstly is to have a joint clinical vision about what we're trying to create. We think part of the problem that we've had across Langston, South Cumbria, and part of this competitive nature, is we've never all signed up to and ascribed to what is the clinical vision we're trying to create. So if we got this right as a provider collaboration, what would the health and social care system look like in Lancashire and South Cumbria in 10 years' time? And we're currently working through that. But at this stage, it's a top-down process, but it's to give us a platform to have the conversations, to engage, to be able to really take those conversations forward, and hopefully get absolute alignment in terms of that sort of clinical vision about what are we trying to create. Because if we do that, we can start to have decisions that will take us in that direction. And we don't have that at this point in time. Each organisation has their own clinical vision. There's a clinical vision for not provider and acute in terms of what we're trying to do.
Kevin, I'm so sorry. I think your sound's going a little bit boggly for me anyway. I wonder if you wouldn't mind just maybe turning your camera off. I think we might have just missed that last sentence. We've heard your presentation, but it's just gone a bit boggly in the last few seconds for me. Sorry.
Is that any better?
That's way better for me. Thank you.
Is that better? Okay. So I was talking about creating our clinical vision. Linked to that, second priority is a joint financial strategy that everybody and each of the organisations signed up to and ascribed. And one of the detailed pieces of work that we've done underlying this is a diagnostic, a systems diagnostics, to really understand across our system what are the drivers of our costs and what are the drivers of our deficits. And some really interesting stuff has come from that piece of work. Because one of the assumptions that I think we all made before we did this detailed piece of work is there were some structural issues that were because of the geography, because of needing to have different rotas across a wide geographical area and the like, that meant we had additional costs that we were carrying. What the diagnostics has actually showed is that yet 25% probably of the deficit that we're carrying relates to those structural deficits, but 75% actually relates to inefficiencies across the system. And if we work differently, you know, if we didn't all have to have 4 or 5 of everything and doing everything 4 or 5 times, we could actually be much more efficient and effective, and we believe drive different clinical outcomes. So that's been a really interesting piece of work, and it's at the bottom of our clinical strategy now. It's at the bottom of our support services strategy, and that governance that I talked about previously, the work programme has been driven through there. So we're developing, and we've got a joint vision for our corporate clinical support estates. That's our third priority. Our fourth priority is about recovery and restoration around our elective programme. We've got, as opposed to most parts of the country, our elective programme was decimated through the first stages of COVID. We've got significant 52-week waits. We've got large 104-week waits. And so, again, being able to work together, use our capacity as a system, we think we can get a better outcome and a quicker outcome in terms of the reduction and improvements in our restoration figures. So, again, that's a key priority for us. The fifth priority is how do we work together in terms of the improvement in our emergency and urgent care system. And then the final one is the development of our leadership and our leadership model across Lancashire, South Cumbria, and making sure that we've got that consistent workforce. So if I look at that in sort of macro level, at the very top end, we're trying to develop an overall clinical vision. At the bottom of that, what we're trying to do then is to drive through a quality management system, which is based on continuous quality improvement, that will give and allow each of our systems from a quality perspective to have a standardization and build on what is good in each of our systems. But the overall objective is in 3 years' time, every part of our system will be good based upon how we define good. And some parts of our system will be outstanding, many parts of our system will be outstanding. And that's frankly not where we are at present. So we've got an overall clinical vision. We've got a bottom developing quality management system that will give us consistency across our organisations. And then in the middle, we've got the work programme around the financial strategy, around the corporate and clinical and support services, around restoration and recovery, and about improvement in our urgent and emergency services. So quickly in terms of lessons, governance clearly has to evolve. It needs to be strong enough at any one point in time to allow you to make decisions, but it needs to be flexible enough as the system evolves around you and as the system matures to change. We've done some great work around that. So we've been able to take some really significant decisions around the likes of some of our clinical pathways, stroke being a good example, some of the work that we've done around digital maturity and our digital platforms and coming together, and the work that we've done around restoration. I think you have to have a very bold vision about this because it won't work otherwise, but it has to be supported by very practical next steps. So very quickly, if you've got a bold vision but you don't actually be clear with the system what you're trying to do, I think people will walk away from it. It takes time and it takes resources. So the reality is it takes a lot of my time, it takes a lot of senior people's time, and you have to put time and resources to make this happen. Not everyone will come along at the same time in the journey. So the issues around communication, having a very clear comm strategy and communicate is so important. And then the role of chairs and chief execs is key. They need to be aligned, they need to be behind this, and they need to be seen to be behind it. So it's no good them just saying in a collaboration board that this is the right thing to do. They need to be out there in their organisations talking to the clinical team, giving permission to the system to work in a very different way. One of the things we've really benefited from is that we've had external support through the national team, and they've helped to challenge us and they've helped to guide us on some of this journey. So our next steps then, and I'll finish here, Miriam, to give time for conversation. So our next step, at the strategic level, we need to do more work on this clinical line and our quality.
Any tips for constraining the proliferation of meetings and kind of creating that leadership headspace would be very welcome. That was a question from Caroline, who's in Ned in the southeast. Any reflections on that, Kevin, on how you go about making sure that governance doesn't create too many meetings, and how you create that leadership headspace to make some of this collaborative work happen?
Hi, can you hear me now, Miriam? Is that any better?
I can hear you now, yes.
I keep losing you, unfortunately. Yeah, can you hear me?
We can.
Okay.
Yeah.
Sorry about this. So I'm assuming you can hear me. So
We can.
okay.
Yeah.
So I think you just have to be really ruthless about it. We continually trawl the meetings that we have. We continually make an assessment about whether the meetings are adding value, and if they're not, we do stand them down. Now, I'm sure there are many people in our system who would say that we have too many meetings, and we still do. But you just have to work at this, don't you? You just have to decide whether the meetings are adding value, and if they're not, be absolutely ruthless about standing them down. The other thing that I think is really important is not everybody needs to go to every meeting. You're going to have trust in your team, and you've got to use your team and give them the ability and the freedom to make decisions without you being there and without everybody being at every meeting. So I don't think there's any one answer to it, but it's just continuing to work at it, Miriam.
Thank you. And another perhaps quick one, which was a question from David French. I don't know if he's rejoined the call or not, but he's interested in considering building capital budget or not.
Yes, we are, absolutely. It's one of the sort of key things that we are going to do. So our capital will come in at ICS level for next year, and we will make the decisions together about what's the number one priority in a prioritisation process. So we're absolutely clear on that, and that will give us more leverage in terms of how we use capital. So yes, absolutely, we are doing that.
Fantastic, thank you. I'm conscious we're kind of coming up to time, so one final question from me to each of our panelists, if that's okay.
So one final question from me
to. I'm wondering maybe if I come to Michele first, as she's rejoined us, and then Siobhan, and then Kevin. Is there one thing you would identify which you would have liked to have known at the start of this journey? I'll come to Michele first. I think you're on mute, Michele.
So, what a great question. What would I have liked to have known at the start of the process? I think a little bit more around how, because the difficult issue we had was data sharing, and obviously lots of different data collections in place. So I suppose we spent a lot of time trying to do that in order to meet some of the metric guidance. So I suppose for me, it's about just a little bit more knowledge about some of the data digital platforms. I think COVID helped a bit of that because it did help streamline some of it, but there are a lot. So I think for me, it's a bit more of a knowledge about the data and the digital work. Sometimes we talk about it from a patient point of view, but not from about a management governance point of view. But there's lots, but that'd be one thing that sticks out.
Thank you. It's always a wicked issue, isn't it, the data? Siobhan, anything you'd add to that? Anything from your perspective?
I think that there was probably an easier path to the primary care engagement. If I think back now, I know we covered that when you asked me the question, Miriam, but it felt quite emotionally challenging at the time on a personal level, because there were lots of stakeholders believing that they should be round the primary community collaborative network, and I think I probably would have sought counsel and brought more GPs in to the kind of inner planning team early on, and I think we probably could have got to an agreed position faster and with a little less tension at times. So I think the primary care engagement bit and the route to that, I probably would change if I had my time again.
Good learning, thank you. And Kevin, is there one thing you wish you'd known?
Well, it's isn't it, that it's more properly, you need to put the time and resources in. So it's not something that you can just do as a side piece of work. it has to be the main thing that you push, the main thing that you do, and you have to resource it appropriately.
Great, thank you, Kevin. Good learning. Well, we're coming up to time, so I think it falls to me to sum up briefly and to say a huge thank you to each of our panelists for really rich and also very honest, I think, and frank presentations. So thank you to all three of you, much appreciated, and we really appreciate everyone's time at the moment. We know how busy it is. So for me, just a few messages that stayed with me. I think I heard, as we always do in these conversations, that the investment in relationships and changing behaviours and building that cultural piece is really key. But we also heard a lot, I think, about the opportunities for a collaborative arrangement or new arrangements to give voice for different services. Thought that was really interesting, as was the focus on how you use a collaborative to drive quality improvement and to tackle some of those inequalities that we're seeking to do. And I was also really interested in something I think all three presenters said, was that governance is important, but it's got to evolve as the task or the aims of the collaborative evolve. That was really interesting. So thank you ever so much. Please do fill in your evaluation forms for the session when they come round, and that will enable us to tailor future sessions to your needs. This is part of a series, as I mentioned, so we do have a further series of 3 further events on different aspects of provider collaboration set in the diary. So do look out for those, and we'll send them a reminder, I'm sure, with the follow-up to this event. So just remains for me to say a final thank you to everybody. Thanks again to the panel and to all of you for engaging today in a busy time. Wish you all a very good afternoon. Thank you so much.